Today I will talk about OPD services. This is part of my series of lectures on hospital management. This is my lecture outline. First, I will talk about functions of OPD, followed by factors affecting expected workload and workload handling. Then I will talk about OPD planning, including principles of planning, location, size, and zones of OPD, OPD manpower, OPD reception, consultation fee, daycare center, and prevention of overcrowding. After this, I will talk about matrices, KPI, and performance evaluation of OPD. Outpatient service. It is an organizational arrangement through which a health service provider delivers healthcare to non-admitted patients. Outpatient clinic. The term clinic describes various arrangements under which service providers deliver specialist outpatient service to non-admitted, non-emergency department patients. OPD service, various locations where OPD services can be delivered. OPD service can be delivered in main outpatient area, in hospital ward itself, in procedure room, in radiology, in clinical laboratory diagnosis, allied health service area, telemedicine or virtual clinic area, telephone, daycare center, home visit, and outreach location. Now, functions of OPD. Functions of OPD can be classified into diagnostic functions, curative functions, preventive function, educative function, promotive function, and rehabilitative function. This is the list of functions of OPD. First of all, diagnosis is prime function of OPD, an ambulatory or domiciliary treatment, admission or referral for admission, health education, family welfare clinic, which include marriage counseling and planned parenthood, well baby clinic, aftercare and physical medicine rehabilitation service, daycare service, community health care, home care program, where hospital acting as a coordinator, obstetric consultation, school health program, immunization service, nutrition education, control of communicable diseases, collection of epidemiological and social data, including epidemiological surveillance, record keeping, training of medical and paramedical students. Now, factors affecting expected workload. This include location of hospital, availability of other healthcare facilities in the locality, socioeconomic, cultural, and education status of catchment population, prevalent disease pattern of population, transport facilities available, geographic and topographical factors, hospital policy and available resources, and number of hospital beds. As a rough calculation, 5 to 6 patients attend OPD per bed per day. Then workload handling. A registration desk can handle 12 to 30 patients per hour. A doctor can examine 40 to 45 patients per day. Pharmacists can handle 80 to 120 prescriptions per day. Now, OPD planning. First of all, planning principles. The general principle is that form follows function. So, design should be as per function. Flexibility, expandability should be kept in mind while designing OPD. Consideration of external and internal traffic pattern should be done. Labor saving devices and automation should be considered. And provision to tackle emergency should be there because about 10% of OPD patients may develop emergency situation. So there should be communication between OPD and emergency department. Location of OPD, it should have direct approach from main road. It should be segregated from inpatient area. It should have easy access to hospital diagnostic facilities, including a clinical laboratory and radiology. It should have connection to emergency departments, as we have seen in my previous slide. Size of OPD, it may be according to bed strength, as we have seen that 5 to 6 patients attend OPD per bed per day, or 500 patients attend OPD per bed per year. The size may be calculated according to local population. About 3 times of population attend OPD per year. Space requirement is 0.67 to 1 square feet per annual outpatient visit. And this space can be distributed into multiple floors of multi-story building. There are various zones of OPD. So first of all, entrance zone, where there is parking area, entrance hall and waiting area, inquiry and registration desk, medical social service. Then ambulatory or joint use zone. I'm sorry, this is all. It has clinics, pharmacy service, treatment room, and minor OT room. Then diagnostic and support zone. It has clinical laboratory services, center specimen collection center, radiology service. Then administrative zone. Here we have office of OPD in charge. Usually it is of the rank of deputy medical superintendent. Then nurse station as administration control, cash counters, medical record room, then staff utilities, including duty room for staff, stores, housekeeping, conference room, and seminar room. So these are various zones of OPD. Then manpower of OPD. So in charge is of the rank of deputy medical superintendent or civil surgeon. Then we have receptionist, data entry operators, help desk personnel, patient relations executive, nursing staff, attendants for queue management, and health educator. Now a brief about OPD reception. We should have a well-groomed front office staff who is trained in soft skills and who is well aware of all procedures. Then we have patient relation executive. We should have efficient billing system. We can use token or ticketing for patient turn with electronic display screen. There should be availability of magazines, newspaper, and TV for waiting patients. We can charge a token fee for OPD consultation and diagnostic services. We can have different charging for off-peak hours to distribute patients uniformly. And we can charge different fee for first and subsequent visits. Daycare center. Daycare center is for those ambulatory patients who do not require full professional inpatient care, who are convalescing, who require diagnostic service, who require short stay. Example include Thalassemia Daycare Center, daycare for psychiatric patients, for radiotherapy patients, and for physiotherapy patients. Then prevention of overcrowding. This is very important aspects of OPD management. We can prevent overcrowding by proper layout, as I will see in my next slide, by using queuing theory, by using appointment system, and by special clinics at other time. For example, in afternoon hours, special clinics can be held. So this is centralized layout where we have multiple clinics and a central OPD registration. Here all the patients wait in a waiting area, and there may be as a disadvantage element of confusion that where these patients should go. Then we have decentralized layout where we have OPD registrations for different clinic and patients directly go to clinic after registration. We can use queuing theory for better management of overcrowding. Queuing theory involves an arrival process, which is usually a poison distribution. Then there is a queue discipline, and there is a server. Here the server is clinic, and the service time is usually negative exponential distribution. Then metrics and KPI. So metrics and KPI can be divided into demand and capacity metrics, access metrics, resource utilization, quality measures. Demand and capacity metric include, for example, number of clinic hours available. Access metrics include various wait times. Resource utilization include OPD attendance. Quality measures include patient satisfaction survey. Then performance evaluation can be done by medical audit committee, which does audit of random cases every month, and it covers every functional area of OPD. We can also assess performance by using patient satisfaction survey. So this is all for today. Thank you very much.